Recording in progress.
So good evening all. So I welcome you all for today's scientific discussion on the pharmacogenetic, the personalized medicine in psychiatry. So my name is Prashant. I am from marketing team of Health and You. So I welcome you all, the eminent psychiatrists from Pune, as well as the psychiatrists who has joined us on through virtual media. So I welcome you all once again. Health and You always together a joint venture with Newlink Corporation Japan. So we'll take only 2 minutes to just brief about the Health and You. So Health and You is a multinational company with 33% stake from the Newlink Corporation Japan, and company has business operation has started in 2011, and company's main focus is into the neuropsychiatry. So the Health and You's vision is the healthcare is a fundamental right of human being, and it should not be denied due to the lack of awareness, access, and affordability. So Health and You will always strive to fulfill unmet medical need for the people by providing the unmet healthcare need by awareness, access, and affordability. So Health and You will always strive to get the world's best services and product from the developed market like USA, Japan, and Europe. Next. So Health and You is present all India. Presence is there, and most of the product of Health and You are first time in India, like Amnuride, which is the first time in India, amitriptyline plus mecobalamin. Then Brentamine, the first vitamin therapy for migraine with the high dose of riboflavin 200 mg and magnesium 200 mg for migraine prophylaxis. Then Health and You is first to bring amitriptyline propranolol as an Amnuride beta available in the 5 mg plus 20 mg plus 10 plus 40 mg. As well as Health and You is first to come up with the low dose of clobazam, 2.5 mg. Earlier only 5 mg, 10 and 20 mg of clobazam was available. So Health and You first to launch Adclobas 2.5, 510 mouth dissolving tablet for daytime anxiety. Backride is our another baclofen, which is the smallest tablet, also available at 54% lesser price at compared to the leading brand in the market. And we are the first, only one to import the mecobalamin injection, Neurite injection, which is only one and only made in Japan, Neurite injection, and the Neurite active, which is the L-methyl folate, mecobalamin pyridoxal 5-phosphate combination as per the US FDA composition. Next. So today, this legacy of Health and You to bring the unmet healthcare need. So this time, it is not a product, but it is the solution for the psychiatric patient, that is the gene scan. To explain about the gene scan, what is the gene scan, what is the personalized medicine. So we have with us the eminent psychiatrist of India, Dr. Vidyadhar Vatve sir. Sir is the leading psychiatrist of India and the past president of the Indian Psychiatry Society. So I invite Mr. Mahesh to felicitate Dr. Vatve sir. To talk on the pharmacogenetics for the psychiatry and what are the in detail, we have the pharmacogenetic expert with us, Dr. Kedar Joshi sir. He is a MD pharmacology and pharmacogenic experts from our partner lab, Genome Bio. So I request Santosh to hand over and welcome Dr. Kedar Joshi sir. So that is from my end. So thank you very much. And I request Dr. Kedar Joshi sir to take over the session and proceed for the next session.
Cheers. All right, so good evening, all of you. It's really a pleasure to be here again, third time in the last 3 years, actually. It's always, an honor to speak in front of you. The first lecture which I delivered in 2019 was so the first lecture that I delivered 2020, we talked about actually not only in research field now. Session was dedicated to till the 2020 presentation from my side on pharmacogenomics in psychiatry. Today, there are two updates actually. One of the update is shared by the HNU executive right now, that there is an administrative and logistic update that Genome Biotech or GenSupport, the lab which actually pioneered in developing this test or panel for psychiatrists, is being looked after by the Health and You company, and they are taking it pan-India. So that's regarding the administrative and logistic update. In my presentation, probably I'll be, taking you to some of the recent advances or the recent evidence that is generated regarding pharmacogenomics. It is often called as personalized medicine or precision medicine, or there is a slight difference between personalized medicine and precision medicine. Personalized medicine is the medicine is that is are practicing day in and day out based on its clinical characteristics. Getting into further details of personalized medicine, to get the maximum benefit of the taking the person's profile into some phenotype and then tailoring the treatment accordingly. No matter how many new drugs are developed, how many new strategies have come in, treatment guidelines that have emerged so far, the STAR-D study or the CATI study or STAPE-BD study, they all try to actually so they try to actually tailor a protocol for the condition, whether it is depression in STAR-D or the bipolar disorder or the schizophrenia in CATI. They try to actually enforce a protocol with the existing drugs and the newer drugs that are coming to maximize the efficacy and reduce the adverse effect profile for that individuals, so that the patient will get the maximum benefit out of the treatment that you suggest. However, all these big landmark studies have failed to show the efficacy or the treatment which can be beneficial to a maximum number of patients, like 100%, 80%, or 70%. So most of the studies have reached to the conclusion of about 50% and so on and so forth. So some of the highlights from these studies I try to get as a background facts, like rate of response to initial antidepressant treatment was only 49.6%, so around 50%. So that's the initial rate of response. 30 to 50% of the patients in major depressive disorders do not respond to their first antidepressant. That is one of the outcomes of these studies. Only 30% of the patients with MDD, BD, or schizophrenia remain compliant, full and stable remission. So the outcome that we are looking at for the treatment is stable remission and compliance. So compliance is lacking, probably is because of lack of efficacy or more of the adverse effects. So it is 30%. You can guess, you can see the numbers that those were enrolled in these studies. The remission rates for SSRIs are as low as 37%. So SSRIs are supposed to be landmark in the treatment of depression. This drug or the pharmacotherapy is supposed to be a landmark in treatment of depression, but still the remission rates are as low as 37%. So major determinant affecting therapeutic outcome that we pharmacologically say side effects and non-satisfactory efficacy relation between the dosage and systemic exposure of the drug. So going by the thumb rule in pharmacology, the dose that is given to the patient, how much it goes into systemic circulation and how much that can reach to the site of action and then have the effect. So as far as today we know that plasma levels are related to the efficacy or safety profile or the adverse effect profile. So that's the major determinant in the response to drugs. So the kind that you see where we are looking at 50%, so 50% are not responding, 50% responding, but still some of them are not satisfactory responding. So this variation is what you see in your day-to-day practice. So a patient who is put on escitalopram may respond well, but the same profile of the patient, the clinical profile of the other patient, he may not respond to escitalopram. So that is the variation we are talking about. You are looking at it in the day-to-day practice, but look at this. Dr. William Osler, or who is called as Sir William Osler, he actually defined or quoted variability, that it is the law of life and no two faces are same. So no two faces or two bodies are alike, and no two individuals react alike or behave alike under the abnormal condition which we know as disease. Dr. William Osler is also known as father of modern medicine. So if we were not for the great variability among individuals, medicine might be a science and not an art. So when we say it is science, it is not perfect. Science is not always perfect. So you may have some queries, you may have some problems with the scientific, because it is not mathematics. 2 + 2 is not 4 in science. So we call ourselves not only, the physicians or clinicians, but it is the art that we practice, because we look at the individual and look at the individual's profile and then try to, suppress his symptoms or treat him as expected. So it is as long as 1849 to 1999, that was the era when Dr. William Osler actually quoted variability in medicine. Now coming back to personalized medicine, when I said that you people are already practicing personalized medicine in psychiatry, it is also not a new word, because Dr. Osborne, who is an eminent psychiatrist, in 1952 in his textbook Psychiatry and Medicine: An Introduction to Personalized Medicine. So in 1952, actually, he has quoted personalized medicine in psychiatry. So this is what we look at in the clinical practice, the variability in patient groups. So no two individuals are same. As quoted by Dr. William Osler, no two individuals are same. However, we can actually look at 4 different groups in a particular patient population. The most ideal group is having efficacy without side effect or lesser side effects. So that could be a green group. Then there can be a group of patients who will not show side effects, who will not show efficacy also or effect also. So on and so forth. You have this kind of 4 groups, because there are 2 aspects of pharmacology or drug that we are looking at. One is efficacy and safety profile. So 2 into 2 is 4. Those 4 groups are present, which actually you are looking into day-to-day practice. Now, this personal variation in the drug response can be based on age, weight, gender, diet. Yes, exaggerated side effects. Yeah, right. So these are the things that you're looking at. When you're looking at a personalized medicine or personalized therapy: age, weight, gender, diet, then renal and hepatic insufficiency or the function. Concomitant medication is another important area, which is the drugs that can be put on the patient, put on probably antihypertensives, even inflammatory drugs. They can have the impact on the psychiatric medication. Forget about these drugs, because we know actually what they do, but the supplements and the alternative treatments that the patients seek usually is from the Ayurvedic side, where we do not have any, knowledge, neither knowledge nor the evidence on what kind of interaction they can have. For example, in psychiatry or neurological diseases, it is quite a common practice that they actually adopt Brahmi and Jataman C, this kind of supplements. And it is known that Brahmi and Jataman C can induce the hepatic microsomal enzyme system. So they can alter the drug responses. Getting into further details of that, the juices like cranberry juice, today is a fashion, they actually get the cranberry juice. Yes, sir?
You know, only keep the thumbnail video of the speaker so that we can read the. There is no online. You have to see the speaker.
Actually, it should be.
Yes.
Click on
Okay.
speaker.
Yeah, I did that. Yeah. Yeah. And now we will
Hit on what?
immediately create the record.
Yeah. Click
Yeah.
on what?
Yeah. Thank you.
Right. So that is what related to concomitant medication. Then most common habits or bad habits like smoking and alcohol both have a large or very high impact on pharmacology of certain drugs or majority of the drugs. Smoking, nicotine can actually induce microsomal enzyme system, and alcohol, based on the dose and the duration, it can either induce or inhibit the microsomal enzyme system, and so it can alter the drug response. The aspect that you will not be able to judge is based on genetic variation, or the individual who is different genetically. It may not be possible clinically to look into it, and those 4 groups that we are looking at can be only identified at the first go by genetic variation test. Not only psychiatric medication, there are several day-to-day commonly used medicines which can actually get altered because of the phenotype that we are looking at through genetic test. So pharmacogenetics is nothing but application of the genetic information of an individual to pharmacology, and 2 pillars of pharmacology are pharmacokinetics and pharmacodynamics. I'm definitely not going into details of that because it's not a topic of today's discussion. But just to mention, pharmacokinetics is the movement of drug inside your body, which is brought about by transporters, metabolizing enzymes, and CYP450 enzyme system. Largely, we know the CYP450 is present in liver, but these enzymes are present in intestine, they are present in brain also. So the activity of CYP enzymes can start from the ingestion of the drug and the absorption of the drug, then metabolism in the liver, which is largely brought about by cytochrome P450 enzyme system. Then pharmacodynamics, which is receptors brought about by drug interaction with the receptors, or some transporters. We all know serotonin transporters, dopamine transporters, or norepinephrine transporters. They can play a vital role in dynamics. And there are some enzymes like COMT, the commonly known as. So these enzymes can actually brought about the changes in the drug action. Now, the point I'm trying to make here is all these things that cause or that get into result of pharmacokinetics and pharmacodynamics, they are protein in nature. And when you say protein is nothing but a chain of amino acids, and every individual amino acid is nothing but a code of a nucleotide, which we know that ACTG, and that is embedded in your DNA. So this information is present in your DNA, and this coding will help how that metabolizing enzyme or the receptor or the transporter can get manufactured and can get function. So if there is a problem with genetic information, there is a polymorphism in genetic information, it can alter the structure and function of these protein molecules, which are primarily responsible for the drug action. So typically in pharmacokinetics, we have phase 1 and phase 2 metabolism. In phase 1, there are list of enzymes, several enzymes, but CYP is of most important. That is because 90% of the drugs that we ingest today or that we prescribe today are affected by the CYP enzyme system. Then in phase 2, there are several other enzymes like UGT, COMT, TPMT. They can actually change or alter the drug responses. So in pharmacokinetics, the movement of the drug, when we say the movement of the drug, it is the absorption, distribution, metabolism, and excretion. All these 4 things can be altered by transport of the drug or the transporter enzymes and the metabolizing enzymes, and they can alter the pharma levels or the plasma levels of a drug, which can hamper the drug efficacy related to effect as well as the adverse effect. So as I said earlier, in a general population, I'm not saying even patient group, in a general population, there are 40 to 60% of the patients who respond differently to different drugs. Take, for example, common drug like NSAID, any NSAID for that matter, or a very commonly used drug in diabetes, first-line therapy is metformin. These drugs actually show this kind of variation in the population. And that is all related to your profile, the genetic profile. So 1 in 4 drugs today available can get impacted because of pharmacogenetic profile of an individual. Now, as I said earlier, that CYP enzyme system is very important. That is because 90% of the drugs today we prescribe are getting metabolized or affected by CYP enzyme system. And of that, there are about 57 CYP enzymes. However, these 6 or 7, they are very important because they actually can metabolize 90% of the drugs. So on the top list is 2D6, 2C19, 2C9, and 3A4. These enzymes, CYP enzymes, are responsible for most of the drugs in psychiatry that can be, prescribed today. And they can alter the patient's profile and so the effect of the drug. So by doing this test, what we do on the pharmacokinetic side is we profile a patient on a phenotype. So there are 4 phenotypes based on the test. One, we call it as normal metabolizer. So a parent drug or a drug given gets metabolized with a certain rate of conversion, and then we expect the effect or adverse effect accordingly, and we call this individual as normal. When the enzyme is mostly absent, now this is a very crude way to say, but what we say is if there is a homologous polymorphism, so both the copies of the gene, one coming from your father or paternal side and one coming from the maternal side, if both the copies are defective, then we call it as homologous mutation. This homologous mutation can bring about the person or labeled as a person as a poor metabolizer. When it is poor metabolizer, the phenotype is poor metabolizer, no matter how much drug you give, it may not get converted into a metabolite. So a drug will not have any effect, neither effect nor adverse effect. But here, the drug gets accumulated and it can result into side effect profile or toxicity. So the efficacy that we are looking at, it may not be there. Then there is an ultra-rapid metabolizer. When we say ultra-rapid metabolizer, that means the individual will have more than 2 copies of normal gene. So this individual has 2 copies of normal gene, one coming from paternal side, one coming from maternal side, so it is normal. But if an individual has 4, 6, or even 13, 15 copies of the same gene, then the number of enzymes produced will be high and the functionality will be high. So whatever drug you give, it gets converted into metabolite and it will not affect or have effect in both sense, efficacy as well as side effect profile. And intermediate metabolizers lie between poor and ultra-rapid metabolizer, where only 1 copy is defective. So it is a heterologous polymorphism. So where the metabolism is there, but the rate of metabolism is slowed down. Now, this is how these 4 patient groups are characterized. So when you're talking or when you're looking into your day-to-day practice in clinical practice and try to segregate this patient in a different way, that okay, 1 month is gone, now this patient should have responded, but he's not responding. So either you increase the dose to a maximum tolerated dose or you change the medicine. So now with the test, you can actually identify at the first go these 4 different phenotypes. And that actually gives you the liberty to start with a drug that can have the maximum impact to an individual. Yes.
So in the third picture, there is no enzyme acting. I mean, there is no.
This one or this one?
The third.
This one.
The green one.
Yeah. So it is called as.
Yeah, there are more metabolites. The drug is converted. The drug is converted into the metabolites completely. So in some drugs in psychiatry, we can take risperidone. The metabolite itself acts as the drug. So in that case, will it have more action
Yes.
with the given dosage?
You actually hit the precise point. Yes, actually, I was coming to that this, when I'm talking about these 4 phenotypes, it is related to a drug, a parent drug which has an activity.
Yeah.
Okay. Now, when we say that if the metabolite has the activity, then we call that drug as a prodrug. Okay. Now, risperidone, the parent drug also has activity and the metabolite also has activity.
Exactly.
Right. So that is when these things will change. Okay. So in risperidone, if it is a poor metabolizer, now when I say poor metabolizer and it is pictorially, it is showing that it is cross. It is not like mathematics. It is not like, switch on or switch off. The rate is so diminished that risperidone parent drug can cause the adverse effect profile. It will show efficacy as well as adverse effect profile. Whereas here, depending upon metabolites activity, whether it is a weakly active or depending upon weakly active or strongly active, it will have the impact. So you rightly pointed out that this is a very important phenomenon. And when we phenotype a person or individual on these 4 phenotypes, it is not that drug can be given or it cannot be given. It can be given, but you have to know the pharmacology of the drug also. Now, coming back to again giving an example, good example for this is today we have, fortunately, we don't have codeine as a separate molecule in India as a painkiller, but we do have tramadol. You must have heard of tramadol. It's a opiate analgesic, and its parent drug doesn't have any activity, but in the body it is getting converted into an active metabolite, which is called which is a morphine derivative. Now this metabolite has activity. So a person, if you have with ultra rapid metabolizer phenotype or status, if you put him on tramadol, he may land into toxicity of morphine. There are deaths reported with that. So that is the importance of this. So knowing not only phenotype is important, it is the pharmacology of the drug also should be taken into consideration. Some highlights on the what I said about these phenotypes. So this is a normal individual where 2 copies of genes are normal. So paternal and maternal side, both 2 copies are normal. And nortriptyline, which is exclusively metabolized by CYP2D6 enzyme system, is seldomly used nowadays, but it is a good drug to understand the concept of pharmacogenomics. So when you dose a person with nortriptyline, this is the plasma concentration versus time profile that you expect with a normal metabolizer. Now look at this. poor metabolizer who has both the copies, which are polymorphism, both polymorphism copies available. So we call him as poor metabolizer. Now look at the peak plasma concentration, which is almost double in this poor metabolizer. And at the end of the 72 hours, the normal metabolizer is coming to somewhere less than 10, whereas this individual with poor metabolizer status is exactly double at 72 hours. Now imagine you are dosing this subject in a given frequency or the known frequency daily, twice or daily once, is going to build up this concentration over the period. And nortriptyline like drugs, which have the adverse effect, which is a dreaded adverse effect related to cardiac arrhythmias, this patient can land up into that. Now, whether I can give nortriptyline to that poor metabolizer. So knowing pharmacology and pharmacogenomics, yes, I can say I can give, but with a maybe homeopathic dosage, micro dosages, and see. Of course, if there is no other choice available, but if you have some good choice, then you shift the person to another drug. So that is poor metabolizer. This is normal metabolizer. And look at this ultra rapid metabolizer who has 13 normal copies of genes. So that means the number of enzymes and the functionality of the enzymes is so high that whatever drug is given, the same dosage we are talking about. So whatever drug is given, it is getting churned out so fast from the body that no effective concentration is seen. So this person will not show any effect or adverse effect of nortriptyline because of ultra rapid metabolizer status. Now I can give nortriptyline to this guy, but maybe 100 times or 200 times the dosage. But if I have a safer or the good alternative available, I'll shift the person on the other drug. And this intermediate falls in between, only one copy normal. So the plasma concentration time profile looks like this. So this is a good graph. This is actually a study done in some individuals. This is to elaborate the different drugs that you are quite familiar with. It starts with imipramine and ends with sertraline. So they're all antidepressants. And the impact of CYP2D6 enzyme and its phenotype, like poor metabolizer, intermediate metabolizer. This is a old terminology. Actually, extensive metabolizer is also known as normal metabolizer, and then ultra rapid metabolizer. Now you'll see this is the percentage dose adjustment which is required as per the metabolic status, the phenotype of the individual. So check imipramine. Poor metabolizers, only 28% of the dose is required, not the 100%, the therapeutic dose that we are looking at. And for ultra rapid metabolizer, it is almost 180. So you quantify that accordingly. So this is for imipramine, whereas sertraline, this is hardly any adjustment is required. That is because sertraline is not a substrate for CYP2D6. It is metabolized by CYP2C19. Primary metabolic pathway is 2C19. And therefore, on this side, you will find the drugs, citalopram, escitalopram, sertraline, they hardly require any adjustment based on the 2D6 phenotype. But the drugs on this side will require higher adjustments based on the phenotype. Similarly, for antipsychotics, again, 2D6 is a substrate. You will find the same graph, the phenotype is here, percentage dose adjustment is here. Perfenazine requires dose adjustment from 30% to about 170%, depending upon poor metabolizer to the ultra rapid metabolizer status, whereas pimozide requires hardly anything because it has a different, metabolic pathway. So whether this test is ready for clinical practice or not, that was the question asked by several practitioners, clinicians in 2019 when we started. Whether it can be used in clinical practice or not is based on analytical validity, and clinical utility. I will not go into details of each and everything, but just to touch upon the points, analytical validity, yes, whether it is there or not. So this means that whether the test can be done, which is reproducible, which is accurate, and which can be done across the world. So yes, it is available, because you all probably is knowing that human genotyping project was completed about 5 years back. It was a horrendous task of about 15 years, and then they came out with something called as genome-wide association studies. So after mapping the human genome completely, whatever polymorphisms or SNPs that we found out, there are about 2 million SNPs we are looking at today after GWS or GWAS studies were done. Not all these 2 million SNPs are harmful. They can be beneficial SNPs also. SNPs, when I am referring to, it is single nucleotide polymorphism. So these studies have shown and actually have correlated with certain diseases, certain phenotypes, and certain advantages or disadvantages. So it is a work of about 15 years, and the entire world was working on that, including some of the Indian scientists also. Then these assays were validated. So there are validated assays which are run across the world. So a lab in Pune, lab in Delhi, they will do the same assay as prescribed. And the laboratory and technology, which is ever increasing. The technology, as you see, it is so rapidly changing that the day we started, we used to require about, say, 4 to 6 weeks of reporting time. Now it has come down to 2 to 3 weeks. So the technology is changing rapidly, and you can actually map the entire genome of an individual with a single test. And that can be even your saliva, not blood, even saliva, you can do that test. So the analytical validity is there, all validated assays from regulatory world like USFDA and EMA, etc. Then on clinical validity, whether data is there or not. So most of the PGX studies which are there in force today, they are related to PK or pharmacokinetics, where absorption, distribution, metabolism, mostly related to drug enzymes, which are metabolizing enzymes like CYP. Then there are outcome studies where symptom reduction has been looked into, then therapeutic response has been looked into, and side effects are looked into. I'll just touch upon some studies a little later. Plus, there is an information from GWAS studies, then retrospective confirmatory cohorts, prospective RCTs, meta-analysis. So all these studies are available today to refer to at. Some of the studies that are big randomized studies. This one with flavin, a significant increase in response after 8 weeks of antidepressant therapy when genetic information of 2D6, 2C19, 1A2, SLC6A4 is a transporter for serotonin. So it is solute carrier family transporter, which is for the serotonin, and HTR2A is serotonin 2A receptor. So when you have the information regarding this, the response or the responders, the numbers are increased after 8 weeks of therapy. Of course, the numbers are 114 and 113 in the control group. Now, whether these numbers are sufficient or not, if you go without genetic study and do this kind of study, genetic test, and if you do this kind of study, the numbers you require could be probably thousands. But when you have genetic information available, these small numbers also can give you a statistical significant results. This is also a study which is published in Clinical Psychopharmacology and Neurosciences, done in Mayo Clinic, if I'm not wrong. Again, two groups were formed. One received genetically guided dosing, the other received the routine based on clinical practice. So you can see the difference between remission rates in the guided arm, which is 72% compared to 28% in unguided arm. Intolerability rates are 4% and 15%. Sick leaves are 4% and 15%, and average sick days per month are 4.3 and 7.7. So these are the parameters they are looking at by comparing two prospective groups. There are such few more studies getting into higher numbers, like more than 600 or close to 700 patients. Again, the parameters that those were assessed were same, and they found that PGX improves outcome in the guided arm than the non-guided arm. Then phase prospective randomized control studies between 2013 to 2019. And the numbers we are looking at are more than 1,000. Again, the outcome was same. Then there is Jukic et al. Published in 2018 with 2,000 subjects, and it has the same outcome. Especially, this study is important from Indian point of view because today, I'll come to this point because 2C19 ultra-rapid metabolizers or phenotypes are seen in high numbers in India. Now, whether you and me are on the same page on clinically, you're clinically, I am on the theory side, or you can say publication side, we can discuss this, but you can see a massive, difference between the individuals who receive citalopram, escitalopram, or sertraline dosage because they are metabolized by 2C19, and we have wide variation on that. Now, this 2,000 subject study on escitalopram again confirmed that if you have that information, genetic information prior to starting the drug, you can have the better responders. In the recent advances, this is the review which is published in the last year, 2021. I would say this is not only a review, but it is a consensus on pharmacogenetic testing in psychiatry. So, psychiatrists and the investigators working world over, this is not visible, I know, but the psychiatrists and the investigators working world over, starting from US, Canada, EU, Japan, Australia, they have formed this consensus, and they have come up with a conclusion or the recommendation, which is definitely in favor of testing genetically for the individuals. Now, a question often asked is, this is all Western data, whether it is applicable to India or not. Well, if we adopt a drug which is tested in the Western population with the same efficacy, with the same pharmacokinetic or the pharmacological aspects, then this also should be adopted. However, the frequencies might be different on the phenotypic side, but ICMR has conducted a survey across the country, and this is published in 2014. I'm just touching upon some highlights which are relevant to this discussion, but they have gone through the entire CYP phenotyping of the individuals in the metros and class 1, class 2 cities, urban and semi-urban population. And you can find that 2D6, there is a percentage of 2 or frequency of 2 to 27% of poor metabolizers, those are seen. 9, 14, and 17, these are nomenclature which we don't have to go into details, but they are not detected. These are detected in the Western population, but these are not detected in Indian population. However, a new phenotype in poor metabolizer was detected in India, which is having high frequency of 12.5. So this is regarding 2D6. For 2C19, you can see a prominent phenotype in Western population, which is only 1 to 2% in Indian population. But the another phenotype of poor metabolizer, which is 19*2, is 33 to 37%. Now, this is where I was actually talking to, whether you and me are on the same page or not. So whether you are seeing that difference between the effect of citalopram, escitalopram, and sertraline is based on this, because the poor metabolizer status is found in 30 to 37% in Indian population, especially in the urban class 1, class 2 cities and metros. Another important point is the ultra-rapid metabolizers for 2C19, which is 19.2. So it is close to 20% of the individuals probably do not respond to citalopram or escitalopram recommended dosages. So that could be very important because it is psychiatrists, but even physicians have started writing this drug very another B, which is human leukocytic antigen, which tests for the hypersensitivity or allergenicity of a particular drug. Regarding this, I'll come to the evidence on the carbamazepine a little later. But this is the data that we have in our lab. Now, this is slightly old data, but we actually stopped going into further analysis. Yes, sir.
This is relevant at this point, but if we are going to assess CYP families, and there are 57 enzymes, and more than one subtype from metabolizes different molecules, or for single molecule there are different. So rather than measuring the enzyme levels, if we just measure the plasma level, the drug plasma level, and metabolite plasma level, will that not be more economical and effective?
Well, I have answered to that in two ways. One is doing plasma levels of each and every drug is practically impossible on the economic side as well as the functionality side, because the kind of equipment that you require is LCMS and the higher grade equipments. Those are not available routinely, and you cannot go for the checking of that. The second thing is whether you will be looking at the plasma levels on day 1, week 1, week 3, or week 5. So at the steady state or where. So you require that kind of time to be invested in that and dose the subject for that. So it is not only a bit of complicated thing, but you are exposing the individual for the trial and error as per se. So after getting that result, if you go back and change the drug, then you again land up into the same methodology. So that we are trying to avoid here. Yes, sir. No. Require any prerequisite. The only prerequisite that we require, the mouth should be clean. So no contamination in that, because genetics is not going to change. It is going to be there, throughout the life.
But what we see in the report is even after testing, we get only advisory signs, and they're not completely precise. Like give this dose or do not give that dose. You are likely to see in that context.
Yes.
Plasma level was more like we phase 2 studies and
Yes.
to individual.
Yes.
Then you will still argue that plasma levels are not representative of CNS levels.
Right.
And that for that I have no answer.
Now, it's there in the next subsequent slides. But I mean when we are trying to test a particular polymorphism and labeling that person into a phenotype, we are they are actually categorized as major pathways and minor pathways. And therefore, I said that 2D6, when we label that individual as a poor metabolizer, it is not switch off. So the metabolism still goes on with alternative pathways, but the major pathway will have the impact. And I have a slide on that also, that what we are looking at it in the future. But yeah, coming back to this, the data on file. Yes, please. No matter. No issues.
Just 3 points. First thing that you mentioned that in our population, Indian population, different, and in the Western population, different types of we we are reading from Western books, and 2D6 has been found to be a major metabolizer for three main classes of drugs, as far as I can remember.
There are many actually,
Yeah, the first
antihypertensives are
one-
there, then NSAIDs are there. Yeah.
The tricyclics
Yes.
and the SSRIs.
Yeah.
So they interact with each other and they increase their
Metabolism.
they increase their levels in the
Yeah.
blood.
Yeah. Poor metabolism.
So is this data applicable to the Indian population or no? That's the first question.
Yes. That is here.
Yes. Where it-
Yes.
26.
So these are the three things which are not identical to the Western population when you compare Indian population. But
So what we did in the textbook.
these are present, okay, and they are labeled as poor metabolizers by world over. Okay. Now this is found in typically Indian population, especially in North Indians, which is 12.5 frequency. Now it has been getting added into the world library. So it is designated as a poor metabolizer. So it is not like we are having a different phenotype totally. There are certain polymorphisms which are seen, which are labeled as poor metabolizers. Those are seen here. So it is not entirely different.
My second question is that citalopram is now has been withdrawn from the market because of its various side effects, cardiac side effects. So we now use only escitalopram. So in that, in our textbooks, it is given that all SSRIs are the same, are same effective, but if you go deeper and read a chart in the textbook, then each SSRIs have different indications according to the
Symptomatology. Yeah.
diagnosis. Like for if there is predominant anxiety, we use paroxysm, and sertraline is applicable to all the diagnoses. And in the escitalopram column, it is given plus only for MDD, not for any other disorders. So, but in India, we have observed that it works for anxiety as well. Slightly.
Okay.
So, is it because of this enzyme or this CYP2C that we find in?
See, to answer your questions, two questions I can see. First thing is, all SSRIs are same. Okay? Pharmacologically, they are same. Pharmacologically, effectively, they are same. But fluoxetine, paroxetine, and fluoxamine, they are primarily metabolized by 2D6, whereas escitalopram, citalopram, and sertraline, they are primarily metabolized by 2C19. Now, their alternative pathways are, again, for 2D6 it is 2C19, for 2C19 it is 2D6, the alternative pathways. Okay. Now, the differences between the labeled indication is based on the studies those are performed for those individual drugs, and that is how they get added every individual indication for that drug. So citalopram is used, or escitalopram is used for anxiety. Yes, it is used, but whether you can use paroxetine or not, now that depends on the clinical side. Getting it? So fluoxetine, when you look at it as a longest half-life drug, and paroxetine with a shortest half-life, now you have those clinical indications whether to write it for an individual or not. Right? So whether you are giving it for PTSD or you're giving it for an acute episode, you'll prefer a short acting. Right? So longer acting are preferred only when the chronic situation develops. And that too, whether it is excitatory or inhibitory, central nervous system wise, whether causing a sleep, drowsiness, or it is causing excitation, that also depends on the clinical characteristics. Now these things are not answered by the pharmacogenomics. Okay. Smoking, alcohol, drug of abuse, concomitant medications, and diet. There is no answer to that on, because even right. So even if I write a patient, even if I label a patient as poor metabolizer, and this patient takes carbamazepine rather, he's going to induce the microsomal enzyme system and he's going to become a metabolizer. So smoking will also cause. There are many antipsychotic drugs which do not show response because of the chronic smoking. That is because the microsomal enzyme system is, stimulated. So these are the things which we will have answers with genetic testing in 10 years down the line. That which enzyme is going to cause what, and which environmental factor is going to cause what. So those things will have the impact in 10 years down the line.
And so one last question. What's the cost of this?
Welcome. Probably you're dialing the wrong number. They will come and answer that.
Right.
Yeah, we'll come to that. Okay. So this is a data on file. We did not go much into details. I mean, we did not progress on this study further because 140 subjects which came for testing maybe a year back. The data shows the phenotyping profile same as the ICMR survey. So in population that we tested, this for 2D6 and 2C19, you'll find the similar kind of numbers that those were actually presented in the ICMR survey. So it was rather a more confirmatory test for ourselves in the lab that the ultra rapid metabolizers 5 in 136 subjects is somewhere coming to, and we call ultra rapid and rapid metabolizers as same. So it comes to 25 and 5, that is 30. And the numbers mentioned in ICMR is 33 to 19.2. So that is what we are looking at. So it was more of a validation from the lab data that we produced. And therefore, we did not go further into increasing numbers and analysis. And obviously, we did not publish this because the data belongs to the doctors, some of them sitting here. So HLA-B, as I said, a very wonder drug, I should say, carbamazepine, used for as a mood stabilizer, or it can be used as a the neuropathy drug. It's cursed with something called as Stevens-Johnson syndrome, which is a very dreaded adverse effect. Now, widely used drug, but the prevalence of having this kind of allergy is 10% world over. Whereas in Southeast Asian population, it is 15%, and in Indian population, it is 2 to 4%. Now, whether to check carbamazepine for this test or not, it is the severity of this symptoms or the severity of this condition, allergic condition, that will dictate this cause. Now, in our lab data of 131 subjects we tested, 6 found to be positive for HLA-B 1502. That is the nomenclature for that particular test. Now, so these individuals, 6 individuals, had higher probability of facing hypersensitivity reaction when put on carbamazepine. Now, this becomes very important because 3 years back, there was a case before the COVID happened. There was a case in Bangalore where a neurologist prescribed carbamazepine, and the patient landed into Stevens-Johnson syndrome. The patient was saved actually, but the doctor had to pay a compensation, a huge compensation, because the patient's relative said that the test was available, but doctor did not do that. And it is just, nobody knew by that time. Even if you ask me, most of the doctors, practicing doctors, they did not know that this kind of test is available. Now, this kind of test is available for certain other medications also, like abacavir, so on and so forth, where hypersensitivity can be judged. the carbamazepine label, the US FDA label, the prescribing information carries that warning that any individual who can receive carbamazepine should be tested for HLA-B1502 test, and if found positive, should not be prescribed carbamazepine. Now, this test is now mandatory in Thailand and Vietnam. That is because the percentages are very high, 15%. So every individual that gets carbamazepine prior, it is tested for HLA-B1502. So the future we are looking at is most of the CYP enzyme, drug metabolizing enzymes, then COMT. This enzyme, the catecholamine O-methyl transferase, I have got a lot of hopes because it comes in the way of lot of drugs pharmacodynamics. So any information coming to that, we will be adding to our test and we'll be proceeding further. But I have a strong opinion that this is going to be a major, a change which can happen in the next near future. Then there are some transporters, norepinephrine, dopamine, serotonin, the receptors. They are today also they are tested for, and in the future, more and more information and validation will occur. So in the future, to answer your question, sir, which I actually forgot, that plasma levels, whether they will be, reflected in brain or not. We are looking at two glycoproteins, which are responsible for, transfer from the systemic circulation into brain or the central nervous system. One is called as ABCB1, and the other is alpha glycoprotein, which is responsible for influx of the drug also from the CNS. So a lot of studies are going on right now on these two molecules, and these transporters will actually define the concentration, the CNS concentration of the drug, and we will have that impact on even the prescribing pattern of the dosing pattern. That's in very near future. The studies we are hopeful and getting, we are awaited the result. We are awaiting the results. Is a larger study which is going on in entire Europe, which is ubiquitous pharmacogenomics project in Europe, and there is one study which is precision medicine in mental health cases care study in United States. This is done by NIMH rather, I should say, because it's a mental health, and in accordance or in association with US FDA. There is an institute in Canada which is Center for Addiction and Mental Health. They are enrolling about 6,000 patients on this study, and the results are awaited. In the future, we are looking at something called as combinatorial studies. Okay, what we looked so far in the last 45 minutes or so, 45 minutes or so, is very simple thing, that 2D6 poor metabolizer, ultra rapid metabolizer. But I don't know how much it is visible, but this is a drug which is fluoxetine. And you can see the impact of about 30 to 35 genes on fluoxetine entire pharmacology. So today we are looking at 3 to 4 genes on fluoxetine, and they are working on this kind of. So the genes that will be tested for individual drug in the future will be 30, 34, depending upon all those primary or major pathways, minor pathways, what will happen in gene expression after the exposure to the environment. So that kind of studies are going on, and we will have that results in near future, 10 years down the line probably. So when we think of prescribing a drug, you get tested and you have the entire profile for that drug for that individual. So that is possible in the near future. Another future study, another study that is conducted in 2011 is related to the weight gain adverse effect of the antipsychotics. So olanzapine and clozapine, today's wonder drugs probably, but they are at high risk of weight gain. So that's Canadian Institute, that CMH, they are looking at this kind of genetic profile for an individual. And today we have a confounding, result or the confirmatory result related to mineralocorticoid 4R gene. So this MC4R gene, which is in terms of simple language, which defines a snacking tendency for an individual. So how many meals a person can have in a day, or who is likely to have in a day, that can be defined by MC4R gene. And this gene status, the polymorphism, will define whether the patient receiving olanzapine and clozapine will have weight gain or not. So not only efficacy parameters, but the adverse effects and the adverse effect because of which drugs are withdrawn or used restrictively, that can also be judged through this test. Now these are the results which are not from Genome Biotech or GeneScan or the panel that we are trying to reach you. All the tests and results, the assays today, the recommendations today are validated world over. There are two groups. One is called as PharmGKB and the other is called as Precision Pharmacogenetic Research Network. So PGRN and PharmGKB, these two bodies world over, they came together and they formed something called as CPIC, which is Clinical Pharmacogenetic Implementation Consortium. So you type CPIC, Google it, or you type PharmGKB, you will land up on this page and you will find all those evidences available for individual phenotype and the recommendation that we are writing. So any report that goes out of our lab is based on the CPIC guide. It is
propensity to develop Stevens-Johnson cardiomyopathy. And there are changes in the gene expression over a period of 5 or 10 years, is that likely to change the susceptibility to develop Stevens-Johnson
No.
after exposure to?
No, sir. It is not going to change its susceptibility because gene expression, the expression of gene takes place when it is exposed to the environment, in a particular environment. By environment, I don't mean that the temperature, climate, etc. But even a drug ingested or substance ingested inside you, that is going to get expressed. A gene is going to get expressed and it is going to form that. So the genetic information in our lifetime is not going to change. Whether it is going to express or not depends upon your exposure to that particular thing. So every walk-in patient, or maybe you can go for difficulty in remission or switching over if you are thinking of switching over, uncontrolled patients or those who are on polypharmacy. Actually, I presented some of the studies in earlier presentation where when multiple drugs can be brought down to, I mean, 6-7 drugs can be brought down to 2 or 3 and the patient is stable. So those are the indications probably when one should go for. Again, I
Thank you. Thank you, Roshi. Excellent, simple, and informative as usual. I have heard him, this is third time that I am attending his lecture. First, I heard in Psychiatrist Association meeting. Next time it was in Tiger Resort near the village, when it was half range, when we had a Indian Psychiatric Society. So the West Zonal CME, and today is the third time. He's very clear, very informative. Talk he gives the simple slides. I think we already had a good discussion. The fact that this, like Dr. Parikh, Dr. Mohan Gupte, and Dr. Deshpande, as usual, when they have already started asking questions, I think we are sure that there will be more and more questions. And here we have Dr. Kedar Joshi to answer this question, or all the questions that you have. I think because of the time restraint, probably we have a couple of questions and then we can have a spirited discussion after that. That means we have a fellowship, spirits together, so we'll have a spirited discussion. I'll just take few. I see. One is Dr. Mohan Gupta, our guest doctor. He's ex-ICMR director, Dr. Mohan Gupta. Very interested. He was in this topic, that's why I invited him. We have got two young psychiatrists from the Medical College. One is Dr. Anurag Borane and his wife. Both of them are working in Sassoon. he is he left Sassoon as a senior resident and now he joined some other private group. Then we have got Dr. Pawar, we have got Dr. Kiran Chavan. All the youngsters are there. As usual, the veterans are always there. Dr. Together and Swatiji. We just start the ball rolling. You can have a couple of questions. Whenever you say, you can have fellowship and come back and discuss it. Over to you, Kedar. Any questions, please?
Can we get some information through the study regarding genetic susceptibility towards addiction or neurocognitive disorders?
Yes, I mean there are some tests available, but we are not doing that yet because we see those tests are called as predictive genetics or clinical. It has to be done in a different setup. You need to have a counseling part, entire counseling part. We are not entered into that yet. So there are about 60, 70 different syndromes and things which are actually tested. But not in this case.
Question actually. I think this was discussed.
Madam, please use the mic.
Yes. So there is something called as epigenetics, right? I'm not very well familiar with it, but still. So just because the genetic information is there, or just because so much of expression is there, does that mean that this test is 100% accurate? And suppose this person will only require this much percentage of a drug or this?
Yeah, to answer that question,
Actually,
See, genetics-
When we talk about differences between Western countries, and I have extra mic for it.
see, epigenetics is, in other words, what's said as expression, gene expression. Okay. So gene expression is in response to some stimulus or some environmental change. But that doesn't mean your genes are going to get changed. They're going to be same throughout your life. It takes generations to change the gene. So the genetic information is not going to change. Whether that gene is going to express or not, it depends on your environmental interaction. And by environment, I don't say, I mean, not only pollution, temperature, etc. But drinking alcohol is also an environment. Smoking is also an environment. So there are different types of genes that probably are dormant, non-functional. They are not expressing themselves, they start expressing. And this study is called as epigenetics. So epigenetics is a study which is looking at the heritable changes, not inherited changes. So heritable changes, if I get exposed, adaptation to say high altitude, some other genes, get expressed which are not there in this unicity. So that is epigenetics. And a large work is going on, including in ICER. They are doing a heavy work on epigenetics. That's why I said those 40 genes that you are testing, whether they are all expressed or not in that individual. If they express, what will happen to fluoxetine? That information will be.
Question?
Sorry? Cost, Santosh.
Yes, sir. Yes. I will, sir. Yes.
I think,
Yeah, just one thing I would like to add here. Just don't look at the cost. Look at the value, whether it is going to add value to your practice or not. Okay. Now, I know in an environment that we are working in, it can be sensitive, cost sensitive, but the value that can be added because it's single time test, it is not going to change. The results are not going to change. Like HbA1c, you don't have to repeat it every 3 months because those results will be lifetime. And I guess we are not only talking about psychiatric drugs or antidepressants and antipsychotics. We are providing some additional 15 about 10 drugs which are like proton pump inhibitors, clopidogrel, etc. That information also get in the action. Because I personally find it interesting that person getting deoxytin or 26 4-metabolizer stimulus, what happens if you get celecoxib or methoxib or the oxides? So those are going to get impacted. Even 26 4-metabolizer patient getting propranolol or risperidone adverse effects, anti-CSS or other extraordinary symptoms, depending on the propranolol, is going to get metabolized by 26. The person is 26 4-metabolizer. Propranolol is going to cause bradycardia for sure. So this is how it impacts. So not only genetic test, but the pharmacology of the drug also should be.
The reason I ask this is because even the richest of the rich patients ask about the money involved in the drugs.
I know.
That Prashant will answer.
Yes, sir.
No matter how much I try to be a marketing
Yeah.
person, I cannot.
Yeah. Like even if, even before the consultation is over, have how much will this drug for? How many months is this going to go on? So if we tell them that you have to do this test so that we can find out the right drug for you, then I'm not sure how the patient will respond. That's why
I'm sure they are working on the patient. The patient information that they are working on, because pre-counseling is very important, and to answer those questions.
exactly.
for the
The
patient.
pre-counseling session is equally.
So they have a literature and in process, I guess. Right?
Yes.
They tell you before that, apparently all these discussions I felt was on adult population. The same thing is applicable to childhood diseases.
Yes, sir.
Or disorders, whatever it is.
Yes, sir. But genetics is not going to change.
Genes will.
However, typically talking about psychiatry in general, not pediatric psychiatry, there are hardly few drugs they are using, and most of them actually can be tested.
Last
People are
question.
more ready to spend on the and then the husbands.
My next question was about allergies. Like HLA-B for carbamazepine. Are there other tests available which tell us about potential of getting allergies?
Yeah, there are certain
One of the seminars that Dr. Wadia said it is related to CYP.
No, sir. Allergic potential is related definitely to the HLA. That is human cholinergic antigen. And however, the tests are different. Like 1502, there is another test 3101. So depending upon drug, like Apagarvin, which is anti-HLA drug, there is an HLA test available. Fenitoin, we are doing in this panel. It has HLA test. Yes, madam.
Thank you, Dr. Joshi.
Thank you, sir.
Excellent. We'll continue the discussion before we finish it. I think I will request Prashant.
Yes, sir.
Tell us about the cost.
Yes, sir. I will take that.
Please.
Yes. I will use this camera. I will use this camera. Yes, I'm just.
Reveal it slowly.
No, sir. So two things, because it is already late. So two, three points I would like to mention here. So one is, sir, that buying process. So first of all, I would like to I'm very happy to announce that we got the association with the Genome Bio. So earlier they have that gene support test. So now it is replaced by gene scan for personalized medicine. So now it is fully automated system now. So buying process is step by step, and all the steps will be automated. So just once doctor prescribe the gene scan to the patient, so patient has to just scan the QR code or go to the gene scan web page and just mention everything about the personal detail of the patient, and patient has to mention the doctor details also. So doctor mobile number and doctor email ID. So every step will be get updated to the doctors and the patients. So once fill up the form of the all the details of the patient, so then he has to upload the prescription, because without prescription we cannot go further. And then he has to make the payment. Once the payment made, so doctor and patient will get the receipt of that, and then automatic process start. From Mumbai, we will dispatch the sample kit to the patients on the given address. Within 2 to 3 working days, the patient will get that. And so we have given the everything in that sample kit. So how to take the saliva sample, how to get it ready, and patient can go to the same link and book the pickup. So once the patient mentioned that I am ready with my sample, and you can come and pick up the sample kit. So within the 2 or 3 hours, so the patient will get the information about that. Yes, your pickup has been scheduled now. So please make it ready. So in that sample kit, we will provide the one envelope also. So in that envelope, the patient can give the sample. And so courier person will go and pick up the sample and will courier to the laboratory. So once the laboratory get the sample, so again the patient and the doctor will get informed. Yeah, your sample has been reached to the laboratory, and within 14 working days or the 15 working days, the sample report will be get generated. Once the report get generated, so patient as well as the doctor, they will receive the SMS as well as the email. On email, they will get a PDF, and on SMS, they will get one link. On that, clicking on that link, the patient as well as the doctor will be able to see the report. And according to that, the patient can get a follow-up and they get the consultation from the doctors. So it is a fully automated system. And after the soft copy generation of the reports, within 3 working days, we will dispatch the actual hard copy of the reports to the patients. It is a simply automated process for the gene scan. Yes. Yes, sir. And sir, yeah. So price, sir, we have kept pricing, that is the 14,000 rupees for the patients. And if the doctor purchase from us and you sell it to the doctors, so patients, so doctor can get 11,000 rupees, because the 3,000 rupees is the analysis charges for the doctors. So doctor read the reports, and on the basis of that reports, doctor prescribe the medicine. So it's like the consultation charge for the doctors. Yes. Yes. Yes, sir. Another that is, yes, sir. And so I'm very happy to announce that online 100 plus 106 to be precise, a psychiatrist got joined with the today's webinar. Today's the CME. So I would like to thank all the online doctors. So those who have joined, and these doctors, all the groups of these psychiatrists from the Pune. And so more information, if you require, or all India psychiatrists require, so our executive will come and will discuss about the more about the process and the pricing and all the references, scientific references. Yes. Yes, sir. So, and at the end of that, okay, I request Prashant sir and Asit, please come on the dais and just give a one small token of appreciation to the Dr. Patwi sir and Kedar sir. Yes. Yes. So once again, sir, thank you, and all the online doctors. I would like to extend thanks to them. So they have taken their time from the busy schedule and joined us. So thank you all. So yes, sir. And now we can proceed for the dinner. Yes, sir. Yes, sir.
Just before we go for fellowship, the small
Recording stopped.